Welcome back to the next session. The first question we are going to discuss here is carcinoid tumors. Okay, carcinoid tumors. Now, from where these carcinoid tumors are going to arise from? What is the cell of origin for these carcinoid tumors? It is neuroendocrine cells. Neuroendocrine cells are the origin for these carcinoid tumors. Write it down. From where they are going to arise from? They are going to arise from neuroendocrine cells. Okay. Now, what are all the sites where you are going to see these carcinoid tumors? One, obviously you already know, in the GI tract. Okay, in the gastrointestinal tract you are going to see these carcinoid tumors. What might be the other site where you can see this? Yes, you can see them in the tracheobronchial tree. So the first site without any doubt is GIT, and the next site is tracheobronchial tree. Yes, GIT. Even 60% of the cases are seen in the GIT. In some cases, around 25% are seen in tracheobronchial tree. Around 25% you can write. So, without any doubt, the most common site has to be gastrointestinal tract only. Within GIT, what are the most common? We'll come to. Right. What is the most common location? Even within the GIT, the most common location has to be small intestine. Please write it down. Small intestine is the most common part which is affected in carcinoid tumor. Okay. And it can even, you can see this even in the stomach, you can see even this in the appendix, you already know, and various other GIT places also it can be seen, but still the most common, if you ask me, without any doubt, it has to be small intestine. Now, this carcinoid tumor, which is arising from the neuroendocrine cells, is capable of releasing certain hormones. Not hormones, I can call it as a vasoactive substances are going to be released. Write it down, what are they? So, vasoactive substances which are going to be released from this carcinoid tumor are one, neurotransmitter, that is serotonin, and the other is histamine. Okay, histamine and serotonin are the vasoactive substances which are released from the carcinoid. Now, some patients, not all the individuals of carcinoid tumor, some patients of carcinoid tumor are going to exhibit the symptoms due to serotonin and histamine. Why not every patient is presenting? Why? Because these serotonin and histamine levels, even though they are going to increase in certain individuals, they are not going to get any symptoms due to this. Only some individuals are going to develop symptoms due to the release of serotonin and histamine. Okay, only in those individuals you are going to see this, called as carcinoid syndrome. Okay, carcinoid tumor and carcinoid syndrome are slightly different entities. Why? Because in carcinoid tumor, it is due to cancer. Okay, but whereas in carcinoid syndrome is seen in carcinoid tumor, I accept, but not every patient is going to present with carcinoid syndrome. Carcinoid syndrome is a clinical presentation of various things which is occurring due to the release of serotonin and histamine. Okay, which is seen only in some cases of carcinoid tumor. Now, what are all the features of this carcinoid syndrome? Write it down. Sweating, flushing will be there. Even you can see bronchospasm as well. Bronchospasm. And in some cases you can even see restrictive cardiomyopathy. restrictive cardiomyopathy can be seen in a carcinoid syndrome. Why restrictive? Because there will be fibrotic right-sided heart valves. So right side heart valves are going to get fibrosed. That is the reason why you may get restrictive cardiomyopathy in carcinoid syndrome. Now, coming to the immunostaining in case of carcinoid tumor. Immunostaining, very important. There are certain immunological markers which you have to remember in case of carcinoid tumor. You already know the moment it is arising from a neuroendocrine cell. Okay, neuroendocrine cell. Obviously, you can write certain markers. What are they? Synaptophysin. Okay, chromogranin A. Okay, these are the immunostaining methods which we are using. One is for chromogranin A and the other is synaptophysin. You have to remember these are very important immunostaining techniques, right? Not only I can check the immunostaining, even I can do one thing called as 24-hour urinary 5-hydroxyindole acetic acid. Very important. 24-hour 5-hydroxyindole acetic acid levels, 5-HIAA levels are elevated in case of carcinoid tumor. Very important this is. So you are suspecting any tumor and on analysis you found out to be 24-hour 5-HIAA levels are increased, then it has to be carcinoid tumor. It has to be carcinoid tumor. Now, what are all the other investigations I can perform in a carcinoid tumor? I can get a CT scan done, I can get a MRI done, or I can get a PET scan done, PET scan done, or I can do a biopsy with the Ki-67. Okay. Now, I have already told you. Now moving to the entities where we are going to see the carcinoid. One thing I have already told you, small intestine is the most common location being for carcinoid tumor. Now within the small intestine, if you see the carcinoid, how to manage this case? If at all there is no distant metastasis, what to do? I can perform a surgery so that I can remove the primary tumor, and I have to remove the regional lymph nodes also. Okay, the moment there is no metastasis, I have to perform surgery. In surgery, what I have to do? I have to remove the primary tumor and I have to do regional lymph node dissection as well. Now coming to what if there is metastasis? If at all there is metastasis, based on patient, the management might be different if it is due to metastasis. Why? Because I can get a radical surgery done on one side, or I can opt a palliative method. Depends on the patient presentation and all. If at all there is metastasis, I can go for surgery and do radical surgery, or the other option I have is palliative method. It is individualized based on the patient. Now, sir, do we have, you are telling surgery, that's fine. On an addition, do we have any medical treatment? Okay, medical treatment for these carcinoid tumors. Yes, there is medical treatment. Write it down. Somatostatin analogs. So somatostatin analogs can be used in case of carcinoid tumor. Sir, tell me the examples. Very important. Octreotide, lanreotide. These are the examples of somatostatin analogs which are used in case of carcinoid tumor. Now, coming to what is the other place where we can see this? Even in appendix also I can see carcinoid tumor, even in appendix also. Now, what is the place in appendix where I am going to see this? At the tip of the appendix. Tip of the appendix is the most common site where I am going to see the carcinoid. Suppose there is a appendicular cancer due to carcinoid. Carcinoid is within the appendix. How to treat this? You already know I have to get a appendicectomy done. Okay. I have to get a appendicectomy. If it is, I have already told you, in general it is involving the tip of the appendix. That is why appendicectomy is going to be enough. By chance, if the size of the tumor is more than 2 centimeter, if the size of the tumor is more than 2 centimeter, or if at all the tumor is invading the mesoappendix. Mesoappendix means what? Mesentery of the appendix only. If at all it is involving the mesoappendix, or it is involving the base. I have told you in general it is seen at the tip of the appendix. But if it is involving the base of the appendix, any of these three things is there, you have to go for a right hemicolectomy. Means you have to remove the colon completely on the right side, you are going to remove. Okay. Now, when to do appendicectomy? In general, you have to get an appendicectomy. Why? Because only tip being the one which is involved. When to get right hemicolectomy? If the size is more than 2 centimeters, or if it is invading the mesoappendix, or the tumor is in the base of the appendix, I have to get a right hemicolectomy. Okay, right. This is all you should know about a carcinoid tumor. Now coming to the next one, that is volvulus. Volvulus, in general they won't ask you ask you directly volvulus only. In general they may ask you gastric volvulus or sigmoid volvulus or a cecal volvulus. So in general volvulus I am going to divide it into gastric volvulus, sigmoid and cecal volvulus. 3 volvulus I am discussing. There might be many, but these 3 are enough for you. Now, within these 3 also, if you ask me what is the most important volvulus, without any doubt it has to be sigmoid volvulus. Okay, sigmoid volvulus is very important. By chance, if you cannot study all these 3 things, my request at least to study the sigmoid volvulus, which is very important. Okay, and the most common as well. Now, first entity I will discuss with you is a gastric volvulus. Right. Means there is rotation of the stomach. So suppose there is a stomach. The stomach can rotate in this direction, or the stomach can rotate in this direction, forward direction also. So it can rotate horizontally or it can rotate vertically. Okay, what is happening we will see. What are the 2 types? First type is organoaxial type. Okay, and the name of the second type is mesenteroaxial type. Under first type, which is organoaxial, let us draw the stomach first. Okay, I am poor at drawing, please don't just a second. Okay, this is your stomach. Okay, right. If at all the stomach is rotating in this axis, suppose the stomach is rotating within this axis, right? Within this axis, if the stomach is rotating, it is organoaxial type. Okay, organoaxial type. By chance, if it is rotating like this, okay, in a vertically, then it has to be mesentero-axial type. Out of these two types, which is most common? Organoaxial is the most common type of gastric volvulus. Now, in general, this gastric volvulus is associated with a condition that is paraesophageal herniation. Okay. Why? Because the transverse colon is something which moves upwards to lie under the left hemidiaphragm. Why this gastric volvulus is occurring? Because what is the trigger point for this? Means there is already a problem in the diaphragm. What is happening around the esophagus? The diaphragm area which is present around the esophagus, there is a problem. So due to that defect, what is happening is there will be paraesophageal herniation will be there. Due to that, the transverse colon which is there, it is moving upwards and it is going to lie below the left diaphragm. As the transverse colon is coming up and it is lying below the left hemidiaphragm, what happens? The stomach is going to be pushed. Due to this, there will be organoaxial rotation of the stomach, you can see. That is the reason why. So, gastric volvulus is associated with what? It is associated with paraesophageal herniation. Okay, now this is what you have to remember. Now coming, this is usually a chronic condition, not, it may not present to you in acutely, it is generally a chronic condition. How the patient is going to present to you? So there is rotation of the stomach, right? There will be difficulty in eating. Okay. How to diagnose this case? Some of you might be thinking, I can get a endoscopy done. Okay, I can get endoscopy, and on endoscope I can see that the stomach is going to be rotated and then I can diagnose. Yes, you are correct, but passing the endoscope tube through the stomach, which is already being in a rotated one, is somewhat a difficult one, and to diagnose is also sometimes it might be a difficult. That is why more than endoscopy, I will do a contrast study. Okay, contrast study is enough to tell me that there is volvulus of the stomach, right? After going through all these things, now coming to the treatment of a case of gastric volvulus. How to treat this case? First thing is, I have to derotate the stomach and I have to fix it. Derotate the stomach and I have to fix it. Okay. In simple terms, what is gastric volvulus? There will be rotation of the stomach, maybe in the organoaxial direction, maybe in the mesentero-axial direction. Which is more common? Organoaxial is more common. Okay. Why this is occurring? Because due to a paraesophageal defect around the defect in the diaphragm around the esophagus part. That is why there is paraesophageal herniation. Transverse colon is going to move upwards and it is going to lie below the left hemidiaphragm. That is why the stomach is going to get rotated. Okay, due to this rotation, this is not a acute entity, this is usually a chronic entity. What is going to happen? There will be difficulty in eating will be there. So you can get an endoscope, but that's fine. But still, much better investigation is always a contrast radiograph. How to treat means you have to derotate it and you have to fix that. This is how you are going to deal with a case of gastric volvulus. After gastric volvulus, we are going to the next topic. Our next topic is about the sigmoid volvulus. Okay, please write it down. sigmoid wall, just a second, volvulus. Now I want to discuss both the sigmoid volvulus as well as the cecal volvulus side by side. Cecal volvulus, nothing more, much more to discuss. Only few points I am going to emphasize on. Mostly we will discuss the sigmoid volvulus. Right. Now, out of all these things I have already told you in the beginning, sigmoid volvulus is more common. It is the one which is more important for the exam. So, the maximum risk of volvulus is seen in the entire GIT is seen in sigmoid volvulus. Why? Because it is the one which has a long mesentery and a narrow mesentery also. Due to the presence of a long and a narrow mesentery, the risk of this rotation or volvulus is mostly seen in the sigmoid colon. Okay. Now, one more thing I want to tell you is how the clinical presentation is typically telling us. Elderly patient, bedridden patient. So, if the clinical presentation is in an elderly patient, that to a bedridden patient, you are talking of this volvulus, then it has to be sigmoid volvulus. In contradiction, cecal volvulus is seen in young individuals. Okay, elderly and bedridden individuals, it is sigmoid. Young individuals and healthy individuals, it has to be cecal volvulus. Okay. Now, how the patient is going to present to you here? The patient present to us in a massive distension, massive abdominal distension. Okay, any elderly patient, any bedridden patient presenting to you with a massive abdominal distension, you have to think of sigmoid volvulus. Okay, let us draw the sigmoid here. Okay, just a schematic one only. I am not going into how it is. Right, this is your sigmoid volvulus, let us assume. How the volvulus will be? So this is how the volvulus will be. Okay, in this direction the volvulus will be. This is how sigmoid colon is going to rotate. Now, what are all the investigations I have to do? Investigations: X-ray abdomen. On X-ray, in the sigmoid volvulus, I can see characteristically a sign called as coffee bean sign. You might be aware of this thing already. Coffee bean sign on a X-ray is a feature of a sigmoid volvulus. I am trying to draw, but how much I don't know. Yes, this is how a coffee bean, somewhat. This is how a coffee bean is going to look like. Now, I can even get a CT scan also. I can get done to diagnose this sigmoid volvulus. Now, which is more important means obviously CT is somewhat more superior to X-ray. You already know. Cecal volvulus, nothing more to discuss. Okay, just I am writing here itself. Okay, now, how to treat a case of sigmoid volvulus? Initial treatment is always a non-operative one. Sir, you are telling no, I am not going to do operation. I am not going to do surgery. Then what I have to do? I have to do therapeutic endoscopic decompression. Write it down. Therapeutic endoscopic decompression. Very important treatment. And I am going to remind you, the first step is not the surgery. The first step is endoscopically I will try to get it to the normal position. I have to get a therapeutic endoscopic decompression done. Now I can do, I mean, doing a sigmoidoscopy or colonoscopy, I can get this done. There might be a chance this will be successful, or there might be a chance it may fail also. If at all this is going to be successful, if at all the derotation is successful by doing therapeutic endoscopic decompression, then what I have to do, I have to insert a flatus tube and I have to retain that for 2 to 5 days. Okay. First thing is I have to get a therapeutic endoscopic decompression done. If it is successful, if the derotation is successful, simply I will pass a flatus tube and I am going to retain the flatus tube for 2 to 5 days. Whereas in case of if the therapeutic endoscopy fails, then there is no option for me. I have to go for surgery. What is the surgery? I have to resect that emergency sigmoid resection. Emergency sigmoid resection has to be done and with a Hartmann's procedure. I have to do emergency sigmoid. I have to resect the sigmoid and I have to bring the proximal colon which is there. I have to bring the stump outside. That is Hartmann's procedure I have to perform. This is how you are going to manage a case of sigmoid volvulus. Coming to how to treat a case of cecal volvulus, I am not going for therapeutic endoscopic decompression. Straight away I am going for right hemicolectomy. Okay. Suppose in a patient, the patient is going to I have told you the patient presents with massive distension. Suppose the patient is telling pain. Now I have to suspect ischemia in this patient. If at all there is ischemia in this patient, it's better not to get a therapeutic endoscopic decompression. I have to straight away go for surgery and I have to remove the sigmoid. Emergency sigmoid resection has to be done. Let us try to go through this once again. Sigmoid volvulus is there, cecal volvulus is there. Yes, first we will discuss sigmoid volvulus. Sigmoid volvulus, the maximum risk of volvulus is seen in sigmoid volvulus because it has a long and a narrow mesentery. It is seen in elderly patient, it is seen in bedridden patient. Whereas coming to cecal volvulus, it is usually seen in young individuals. Coming to the clinical presentation in sigmoid volvulus, patient presents to us with a massive distension. Okay. How to treat this case means, how to investigate means, first thing X-ray. What is the sign? Coffee bean sign. CT is very useful and it is the best investigation. Coming to how to treat means, therapeutic endoscopic decompression I have to do. If it is successful, then I have to insert a flatus tube and retain that for 2 to 5 days. If at all therapeutic endoscopic decompression fails, I have to go for surgery, emergency sigmoid resection with a Hartmann's procedure done. Whereas if the patient presents to us with pain, then also I have to go for surgery because there is already ischemia over there. Coming to the treatment of the cecal volvulus, you have to get a right hemicolectomy. This is all you should know about volvulus. Coming to the next question. Next question is about the stricture urethra, or simply urethral stricture also you can call. What is the cause for this stricture urethra? What is the etiology, or what are all the causes for the stricture urethra? There is a condition called as lichen sclerosis. Okay, lichen sclerosis, where there will be sclerosis. Okay, That is one condition where you can see. And post-infectious also you can see due to a sexually transmitted disease, that is gonorrhea. Nowadays the incidence due to stricture urethra due to gonorrhea has been reduced. Why? Because we are using antibiotics and all we are using. Due to that the incidence is somewhat reduced only, but still you can write even in gonorrhea you can get a stricture urethra. I can get I have inserted a catheter, okay, or I have done an endoscopy, okay, post instrumentation. Write it down, post instrumentation. I can get a stricture, maybe after a catheter insertion or maybe after a endoscopy procedure. I can get stricture urethra. Now I have operated the patient. I am removing the prostate, transurethral resection of the prostate I have done. What might be the complication? Stricture urethra might be the complication. So post transurethral resection of the prostate. Okay. Now, even if there is any trauma to the urethra, I may get a stricture. These are all the causes: lichen sclerosis, sexually transmitted disease gonorrhea, post instrumentation catheter or endoscopy, post surgery, that is transurethral resection of the prostate, and even due to trauma you can get a stricture urethra. What are all the clinical features with which the patient is going to present to us? Obviously there might be some urinary symptoms like hesitancy, okay. Due to the stricture, what happens is the flow which is coming out, the urinary flow is going to be poor flow, okay. Poor flow of the urine will be there, and even the voiding time, okay, as the passage is narrowed due to the stricture, the voiding time is going to be increased. Prolonged voiding time, poor flow, prolonged voiding time, and hesitancy, these are the features we can see. So even the complication which can occur is recurrent urinary tract infection. Whenever there is a little obstruction to the flow of the urine, there is always a complication of urinary tract infection, okay. Recurrent UTI the patient may come with. What are the investigations I am going to do in stricture urethra? I can get a ultrasound done, or I can get a retrograde urethrogram done, urethroplasty done, RGU. These things tell us whether there is stricture or not. Now, how to treat the stricture? How to treat the urethral stricture? One option obviously everyone will be know is dilatation. So what are the other options I have? I can get direct visual internal urethrotomy, and even urethroplasty also there is an option. I can repair the urethra, that is urethroplasty. Okay, stricture urethra etiology, what it is? Lichen sclerosis, gonorrhea, post instrumentation catheter or endoscopy, post surgery TURP, and trauma also. Clinical features: hesitancy will be there, flow of urine is poor flow will be there, and prolonged voiding time is also you can see. Complication you already know, recurrent urinary tract infection. What are all the investigations I am going to do? Ultrasound I can get done, retrograde urethroplasty I can get it done. How to treat this case? There is stricture, I can get a dilatation, or I can get direct visual internal urethrotomy, and the other option I have is urethroplasty. This is all about stricture urethra. Now coming to the next topic. Next topic is about embolectomy. I am not going into complete ischemia part. I am just discussing the embolectomy part only the treatment part. How the patient presents and what are all the investigations to be done, I'm not discussing here. Directly I'm going to the treatment part, embolectomy part. Suppose a patient with acute limb ischemia, I mean, how the patient presents to us with pain and all, and how we are going to diagnose, everything is over. Now the patient came, we have diagnosed this case, acute limb ischemia. I'm not discussing the etiology, clinical features and all. Why? Because I'm discussing embolectomy, direct treatment here. Now, the patient is already diagnosed case of acute limb ischemia. How to treat? First step of treatment. First step of treatment. No, it is not embolectomy. It is not embolectomy. First step, acute limb ischemia. First step. Very good. Intravenous heparin. Very, very important. Any acute limb ischemia, patient comes to you, first step is not embolectomy. First step is always intravenous heparin is the first step. Okay. Now, after giving this intravenous heparin, I have to what to be done? I can do embolectomy done, or I can do thrombolysis also. Thrombolysis is something which is somewhat a medical therapy, whereas embolectomy is somewhat a surgical technique. Whatever you have to follow, it depends on patient, but still the first step in every patient is intravenous heparin. Followed by that you can get embolectomy or you can get thrombolysis also. Now coming to how this embolectomy is going, as they have asked embolectomy, we will discuss how the process is going to be done. Okay. Now embolectomy, I have to get it done under local anesthesia is okay. Even I can get it under general anesthesia also, whatever. Local anesthesia is enough for it. Let us draw this. Suppose there is a artery. This is the artery. There is a thrombus somewhere over here. Which one I should use? Okay, we'll use this. Suppose this is our thrombus. This is our thrombus. How to approach in embolectomy means, the first thing I have to do is I have to incise the femoral artery. I am incising this femoral artery over here. Okay, I made an incision and I made a nick, and now using this I am going to insert my guide wire. Okay, now I am passing the guide wire through this. I am passing it. Yes, now I have reached the clot. Even through the clot I am going ahead. Yes, I have passed through the clot. Okay, my guide wire has passed the clot. Now when I went distal to the clot, this is the place where I have to start dilating this. Okay, now I am going to dilate this. Okay, the first thing is I have to cut the artery, incise. After that I have to insert my guide wire. The guide wire has to pass distal to the clot. After passing distal to the clot, now I am dilating the distal most part of my guide wire. Okay, now I am dilating. After that I am going to pull my guide wire back. So what happens when I am going to pull? Along this clot which is there, this part I am going to already dilate, and this is going to bring back the clot also along with us, and the clot will be removed outside. This is how the procedure of embolectomy is going to be. So what are all the steps we have seen? First thing is I have to do arteriotomy. Okay, a small incision is made within the artery. Usually which artery I am doing? In the femoral artery. Usually in the femoral artery. Now what I am going to do? I am going to insert my catheter. Through this. After which I am going to move my catheter deep. I am going to move forward till where? Till it is going to be distal to the embolus. Till my catheter went distal to the embolus, I have to go on passing my catheter. Now, the moment it is distal to the embolus, what I have to do? I have to withdraw my catheter. Catheter is going to be withdrawn. Even along with that, we are going to get the embolus outside, removing the embolus. This is how the procedure of embolectomy is being done. Okay, thank you for watching.